Hello, welcome back to MLSQR. There are at least 11 questions in the ASCP study guide for the license exam for the MLS and MLT ASCP exam, and we know they are on the CLS exam. I'll show you four simple equations that can be memorized in several ways to help you calculate RBC indices quickly. Why are RBC indices important? RBC indices present helpful clues to help us correlate with a CBC if there is a problem specimen, such as strongly lipemic or icteric samples, or if there's a cold agglutinin present. Also, we can look for clues in the peripheral blood smear, such as macrocytosis, microcytosis, anisocytosis, hypochromasia, and spherocytes. Finally, the red blood cell indices provide the clinician valuable diagnostic clues to the patient's hematological status, such as classifying the anemias according to MCV and assessing progression and treatment of chronic diseases. Briefly, some background instrument info. Whether your instrument is Beckman Coulter or Sysmex, the basic Coulter principle is the principle of measuring individual red blood cells count and cell size through a tiny aperture in a conductive isotonic electrolyte fluid. Electronic pulses are counted with each red blood cell passing through the aperture single file, displacing a tiny volume of isotonic electrolyte saline in a laminar fluid, causing a unit of electrical resistance between two electrodes that is measured as electronic pulses by an oscilloscope. The electronic pulse amplitude is proportional to the cell size, and the average is known as the MCV. A Gaussian bell curve shows the normal distribution of cells according to cell size and number in millions per microliter or lambda, showing the mean and 2SD limits in femtoliters. ACP ranges are 76 to 100 femtoliters. Mean MCV less than 76 femtoliters is considered to be microcytic, where microcytes less than 7 microns in diameter may be seen in the peripheral blood smear. Mean MCV greater than 100 femtoliters is considered to be macrocytic. The MCV is calculated as shown here. Measurement units are shown here. Notice this pattern as we substitute MCH, or mean cell hemoglobin, and substitute hemoglobin in the numerator. Mean cell hemoglobin is measured in picograms with the ACP reference range 26 to 34 picograms. MCHC is hemoglobin times 100 divided by hematocrit. MCHC is measured in grams per deciliter. MCHC is the simple equation to remember as H&H times 100. Once you remember the MCHC is the simple one, now you can worry about MCV and MCH. Again, note this familiar pattern in the equation, times 10 divided by RBC count. Let's calculate MCH substituting hemoglobin. If you can remember that pattern and MCV is linked to the hematocrit times 10 divided by RBC count, then you got it memorized. Another memory tool is to look at all three equations at once. The easy one is at the top, MCHC, which is H&H times 100. And if you put MCH and MCV as number 2 and 3, lo and behold, you have hemoglobin over hematocrit. Another interesting pattern, 10 times 10 is 100. You might like this memory tool using the triangular method. Hemoglobin and hematocrit on the right side, hemoglobin over RBC count on the left side. On the right side, H and H times 100 is the MCHC. On the left side, hemoglobin over RBC count times 10 is the MCH. Credit for this triangular memory tool goes to Ms. Ria Nav, a wonderful instructor of hematology and who published dozens of YouTube videos in her Interesting Learning channel. Bear in mind the MCV is not included in this triangular method. You might have to modify it at the bottom with hematocrit and RBC count. The fourth equation is designed to statistically describe the shape of the MCV histogram. Statistical parameters include standard deviation and the mean average. Note the bimodal distribution of the last histogram with two distinct RBC populations. The fourth equation is RDWCV, or coefficient of variation, which is a measure of the proportion of standard deviation of MCV over the mean MCV times 100%. The Gaussian bell curve of the MCV shows the proportionality of standard deviation over the mean MCV. This description of the distribution shows if it's tall and narrow or short and wide. RDWSD is also mentioned in one question of our study guide. It is more of a graphical representation of MCV variation as it is the width at 20% peak height. If you see a low MCV or a high MCV, try to correlate it with the peripheral blood smear so it makes sense. And there is a micrometer in some analyzers, which you can see. You can measure 6.5 to 7.5 microns in diameter. If the red cell's bigger than 7.5 microns in diameter, then we think of about a macrocyte. Less than 6.5 microns in diameter, microcytes. You can use the normal lymph nucleus as a measuring tool, 7 microns in diameter. One easy way to classify anemia is based on the MCV. A low MCAC will lead one to look for hypochromasia, where the central pallor is greater than one-third of the red blood cell. This is consistent with moderate to severe chronic anemias. A high MCHC above 36 grams per deciliter leads one to be suspicious for spherocytosis. There are many causes of spherocytosis: hereditary spherocytosis, burn patients, severe intravascular hemolysis due to various causes such as autoimmune, hemolytic anemias, hemolytic transfusion reactions, hemolytic disease of the newborn, disseminated intravascular coagulation. There are a lot more. You'll also see in the peripheral blood smear polychromasia, nucleated RBCs, schistocytes, acanthocytes, helminths, and echinocytes. MCH is not as informative as the MCV and MCHC, as MCH parallels the MCV and it is somewhat redundant. Thank you for your time, attention, and support, and I hope to see you in the next video, and we'll have a question and answer presentation.